All right, good morning, everyone. Welcome to another Friday morning AMSSM Sports Ultrasound Case Series. Happy spring to everyone who's finally thawing out and warming up. Today we have Dr. Negron. Dr. Negron completed his medical school at University of Florida, then physical medicine and rehab residency at Emory University in Atlanta. He's currently the AMSSM Fellowship Class Representative, and he's our fellow here at Mayo in Rochester and finishing up his fellowship here in the next couple of months. Dr. Negron is going to be presenting on valgus extension overload.
You guys see my screen?
Looks good.
Perfect. Thanks for the introduction, Dr. Betcher. So my name is Gio. I'm the sports medicine fellow at Mayo Clinic in Rochester, Minnesota. I'm excited to share a case with you all on valgus extension overload syndrome. I have no disclosures. So before we begin, I would like to give a big thanks to my mentors at Mayo Clinic and my program director, Dr. Sellen, and my associate program director, Dr. Betcher. They have been a wonderful asset to my ultrasound learning and have been very patient with me this year. I've been learning the ropes on becoming proficient with MSK ultrasound. As a picture, this picture glimpse of my learning this year. Both of them always striving to teach me something every day. And I also want to give thanks to my mentors at my prior residency institution at Emory University and my medical school and intern year at University of Florida, as these early mentors provided the foundation of MSK learning. So for our learning objectives, we're reviewing the scanning protocol for the ultrasound evaluation of the medial elbow. We're going to be identifying normal and pathological ultrasound findings, review relevant elbow anatomy, discuss the pathophysiology of valgus extension overload syndrome, and finally, we're going to be composing a diagnostic report. So starting with our case, we have a 24-year-old right-handed dominant professional baseball player who presented to clinic with 1-week history of posterior medial elbow pain. He first noticed his pain after a pitching session and felt a pop after picking up and carrying a double bag over his shoulder. Continuing his practice, he reported that his pain was provoked with terminal extension when throwing, and prior treatments included rest and icing only provided mild relief. Otherwise, he denied any weakness or numbness. And as for his physical examination, on inspection, he had no increased erythema or swelling of the elbow joint. For palpation, he was tended to palpate over the posterior medial ulnar humeral joint. For range of motion, he had limited range of motion compared to the contralateral side with limited extension up to 20 degrees and limited flexion only reaching to 132 degrees assessed with the goniometer. He also had pain with terminal elbow extension. On neurological examination, he had full 5 out of 5 strength and his sensory examination was normal. On special testing, he had negative varus, valgus stress testing, negative milking maneuver, negative moving valgus stress test, and a negative Tinel's at the elbow. So for prior imaging, on the left here, we have a lateral elbow film, which shows here on the blue arrow indicating a anterior fat pad sign, which is indicative of the presence of an elbow joint effusion. On the right, we have an AP film, which you can appreciate tiny bone spur at the medial joint line. Otherwise, no acute fractures or osteochondral lesions were seen. So for our patient, as he was complaining of posterior medial elbow pain, we went ahead and picked the medial elbow ultrasound protocol from the AMSSM ultrasound curriculum as our base protocol. The medial elbow ultrasound includes common flexor, pronator tendon and muscle, the medial ulnar collateral ligaments with dynamic valgus and stress views, the medial ulnar humeral joints, the ulnar nerve, and assessment of instability of flexion and extension views. And based on our clinical question on what's causing our baseball players' posterior medial elbow pain, we also decided additional structures to be added to the protocol, with orange text not being part of the formal AMSSM protocol. So these structures included the medial epicondyle, the medial cutaneous nerve of the forearm, the posterior bundle of the MUCL, the posterior humeral ulnar joints, including the Olecranon fossa, posterior joint recess, Olecranon process, and Trochlear, the distal triceps tendon and muscle. And seeing that our athlete had trouble with elbow extension, we went ahead and scanned his brachialis, the anterior ulnar humeral joint and radial humeral joint, as well as the distal biceps tendon. So going over ultrasound considerations, for the elbow joint, I like to use the linear transducer. For this particular case, we use a mid-frequency and a high-frequency transducer. And though we don't use it, you can always consider a smaller footprint such as the hockey stick, especially when scanning around the bony processes of the elbow joint. As other presenters have mentioned, patient positioning is key for the sake of being ergonomic. So as we started with that medial elbow, we have our patient in a lateral decubitus position with their shoulders slightly forward flexed, elbow supinated and extended. We also make sure that the elbow is hanging off the table to allow freer elbow movement. Throughout the exam, we also had his elbow at varying degree of flexion, depending on the structure being investigated. And for the posterior elbow scan, you can elect to have your patient supine and propping their hand on the table. But for our case, we kept our patient in the same lateral decubitus position, moving the transducer to the posterior elbow region. And finally, a portion of our ultrasound examination included anterior structures. So we switched positions and scanned the elbow with the patient's supine, arm extended and neutral. So beginning with our scan, we start with the common flexor pronator tendon and muscle. The image on the right here is a reference for the patient positioning with the blue and orange colored boxes pertaining to the border of the respective ultrasound image. The ultrasound image also has the orientation direction on the bottom left of the image. So on the left here, you have a long axis view of the common flexor tendon. This is obtained by anchoring the transducer on the medial epicondyle and pointing the distal end of the transducer to the middle of the wrist. We noted normal tendon structure without any evidence of thickening, any evidence of hypogenicity or tearing. And taking a look at the medial epicondyle, we see no bony spurs or esthesophytes. On the right here, we switched to a short axis view, which confirmed normal tendon structure, which we appreciate on long axis as well. So we have a cine view demonstrating a distal to proximal sweep of the flexor tendons. And I like to do this to appreciate the individual flexor muscles that can be followed from the distal to proximal end. That can help assess what portion of the common flexor pronator tendon unit is affected when there is pathology. At the end of these slides, I'm also going to be showcasing portions of the ultrasound report. So we have a normal medial epicondyle and the common flexor pronator tendon is also normal. Next is the medial ulnar collateral ligament, or the MUCL. We have a diagram depicting the different bundles of the MUCL, the anterior, the posterior, and the transverse bundles. The anterior bundle is mechanically the most important, being the primary ligament stabilizer during elbow valgus stress. And the anterior bundle originates from the medial epicondyle to the sublime tubercle of the ulna. To best view that medial ulnar collateral ligament, we slightly pivot the distal end of the transducer posteriorly from our view from that common flexor pronator tendon. So now looking at the ultrasound images for the anterior bundle. On the left here, we have a long axis still, and you can appreciate now that there's some, at the superficial side, there's some little mild thickening, hypogenicity, at the very proximal, the mid portion of the ligament. We can also see that there may be a small anechoic defect at that superficial mid portion, possible low-grade intersubstance tear. At the deep side, a deep proximal origin, there's also thickening and hypogenicity. So with subtle stressing of the MUCL, you can appreciate better the separate fibers that make up the anterior bundle. You can see that the ligament is overall intact, but appreciate that hypogenicity better and possibly the anechoic defects in that mid substance. We can also see that there's an intra-articular synovium against that underside surface of the ligament, and this being that medial ulnar humeral joint, I can appreciate now that there's mild spurring at that proximal medial ulna, right where that ligament enters and inserts. So this is a short axis cine, sweeping from distal to proximal. We can see that the MUCL is being this dark shadow with correcting anisotropy with slight tilting motions as we move proximally and distally. With a short axis view, we can always appreciate the converging fibers from distal to proximal, the anterior bundle. And in my experience, continuously looking from long axis to short axis is a great way to assess for suspicious tears, especially in that deep proximal side. So for what we report, the medial ulnar humeral joint, there's mild spurring noted in the proximal medial ulna at the anterior bundle MUCL insertion. The medial ulnar collateral ligaments and anterior bundle is overall intact superficially at the very proximal and mid portions mildly thickened, The deep proximal origin is also thick and hypoechoic. There's a punctate anechoic region in the superficial mid portion that may represent a low-grade intrasubstance tear. So now we move on to MUCL dynamic testing. And for our dynamic testing, we perform a single operated technique with the patient side lying and the elbow placed in approximately 50 degrees. And this 50 degrees has been shown in previous cadaveric studies as the angle for maximum stress at the MUCL. So if your machine is capable, the use of split screen is easy to capture that ulnar humeral joint in baseline and stress evaluation. If you want to know more about the current state of literature and of the MUCL diagnostic ultrasound evaluation, there is a recent review publication from my institution highlighting the various terminologies and techniques for evaluation and stress testing. And to establish consensus, the paper recommended standardizing elbow stress measurements with the term stress delta, which measures the distance of stress from a single joint, normal as being less than 2.4 millimeters of joint space, and the stress delta difference comparing the injured versus uninjured stress measurements, which normal is less than 1 millimeter. All that being said, for our patient, we have a rest view on the left here and a stress view on the right. A tip that I use when I'm gathering these measurements is to make sure that we align the surrounding musculature and soft tissue along with the bony contours to get that accurate measurement. The calculated stress delta was 1.2, which was normal. And though we usually compare contralateral side to obtain the stress delta difference, we felt very confident that the MUCL was normal and not the primary problem, and therefore continued out with the rest of the elbow scan. Our report reiterated this. Now looking at the ulnar nerve, we now extend the elbow and we're scanning the nerve from the proximal to distal, from the midforearm to the cubital tunnel. On the left here, you have a short axis stills of the ulnar nerve across the retroepicondylar groove and into the cubital tunnel. We see no changes in nerve caliber, no changes in fascicular architecture. This is a cine view on the right here that demonstrates a dynamic scan of ulnar nerve instability. I do have a little elbow flexion animation to correspond the elbow flexion movements that we're going to have during this presentation. And in your actual exam, you should make sure to perform full flexion or until the nerve dislocates. So we can see that the nerve here with dynamic elbow flexion stays put. There's no evidence of subluxation or dislocation. We can see that the medial head of the triceps also stays put when dynamically flexed. So a general tip when performing dynamic scans like this is to keep the transducer pressure light to allow the nerve to move freely. So now we have that the ulnar nerve is normal in appearance, no enlargement, and stable with stress testing. As part of the medial elbow, we also like to scan the medial cutaneous nerve of the forearm and dynamically assess it for snapping. To find a nerve, you place the transducer in the medial mid-arm. And on the left here, we have a short axis view where we find a home base of the nerve, where the nerve bundle sits around the basilic vein. Anterior to that, the median nerve and the brachial artery, and posterior to that, the ulnar nerve. As you sweep distally to the arm, you can see it divide into its anterior and posterior divisions. That posterior division then heads to the medial epicondyle, as you can see right here. It's a little difficult to see and appreciate, but as it goes here, we now assess it for a dynamic elbow flexion like we did with the ulnar nerve. With that, we appreciate that there is positive findings of snapping of that medial epicondyle. And though remarkable, this is not painful or recreated any of the discomfort of our patient. And I put this table here just to keep in mind the differential diagnosis for snapping at that medial elbow. This includes the ulnar nerve, the triceps tendon, and the medial cutaneous nerve of the forearm. So for our report, we noted snapping at the medial antebrachial cutaneous nerve was present. However, it is important to note the clinical background behind this, as this was asymptomatic for the patient. Now, still looking at the medial ulnar collateral ligament, we're going to be focusing at the posterior bundle of the MUCL. The posterior bundle is a fan-shaped ligament from the medial epicondyle to the semilunar notch of the ulna. And above it, it crosses the ulnar nerve. Think of the posterior bundle as the hammock or the floor of the ulnar nerve for the retroepicondylar groove. And you can appreciate the transverse cut of anatomy here depicting the posterior bundle and ulnar nerve relationship. So now with ultrasounding the posterior bundle, the MUCL, it can best be seen in short axis at the retroepicondylar groove, making sure that you see that ulna humeral joints with that ulnar nerve on top of it. With these two still transverse images, we can appreciate the posterior bundle is sort of a triangular shaped ligament highlighted in orange here on the right. It's acting as a hammock for the ulnar nerve. And with this cine, we're sweeping back and forth, and you can really assess the anatomy for our patient. You can see that the ligament overall is intact. And seeing that the ulna is on the left, the humerus on the right here, you can now start to appreciate maybe there's some hypertrophic bony changes to that posterior ulnar humeral joint, which was also present in the X-ray images. So for our report, the posterior bundle of the ulnar collateral ligament is normal. The posterior ulnar humeral joint in the retroepicondylar groove, we appreciate a hypertrophic bony spurring that's noted both the ulna and the humerus deep to the posterior bundle of the ulnar collateral ligament. Now in our protocol, we're formally assessing the posterior ulnar humeral joints, specifically now looking at the posterior medial elbow region. On our patient, we maintain the patient in his lateral decubitus position, elbow flex supinated, but we move the transducer now more posteriorly. On the left here, you have a long axis view of the posterior medial elbow region with power Doppler on. In this image, it can be a little hard to tell, but there is some mild thickening of the soft tissue, and with power Doppler, we start to appreciate some hyperemia within the soft tissue of the posterior medial elbow joint. On this long axis cine, we can sweep across the medial epicondyle, the Olecranon. You can see medial epicondyle right here, sweeping now to Olecranon, medial epicondyle. And then we are not really seeing any evidence of loose bodies around this area. So for our report, to add on to the posterior ulnar humeral joints, there's mild thickening, hypocogenicity, hyperemia in the adjacent soft tissues. With these findings, we're now starting to paint a clinical picture of valgus extension overload syndrome. Now, still in the posterior ulnar humeral joints, we bring our focus to the Olecranon fossa in the posterior recess. On the left here, we have a long axis cine with the Olecranon fossa below and the triceps tendon on top. We're now starting to see evidence of what we see here, a large elbow effusion, surrounded by mild synovial hypertrophy, still no loose bodies at the Olecranon fossa. With the short axis cine, this confirms the effusion, and it's worth to note that the Olecranon fossa with the elbow flexion is the most sensitive location to detect these elbow effusions. A power Doppler was also used in this region in short axis and demonstrated no hyperemia or vascular flow. So with all these findings, we're starting to formulate that our athlete's main problem may be an intra-articular one. Our report stating that the Olecranon fossa, in the Olecranon fossa, there's a large effusion with mild synovial hypertrophy, no hyperemia, no evidence of loose bodies noted. Continuing at the posterior ulnar humeral joint, we went ahead and took a look at the trochlea, which you see here in as a transverse still. We can appreciate here that in the cartilage, the cartilage is black and intact on the lateral trochlear side. But as we get to the medial side, it becomes difficult to see. There's some focal region of hypertrophy underneath that cartilage. Going on to report, now along with the marginal osteophytes in the posterior elbow, hyperemic capsular tissue, elbow joint effusion, and now we're seeing subchondral hypertrophy, specifically at that medial aspect of the trochlear cartilage. These are findings that are consistent with that valgus extension overload syndrome. And for completeness sake of the posterior scan, we also assessed the distal triceps tendon. The distal triceps tendon is intact without any abnormalities. On long axis view here, you can appreciate that superficial and deep fibers of the triceps tendon, the superficial being that long and lateral head tendinous portion, and the deep fibers being the medial head tendinous portion. You can also see the medial head muscle belly adjacent to it. And the normal tendon is also confirmed on short axis view. And our report reflected this. Because our athlete was having difficulty with extension, we wanted to see if there's any anterior structures contributing to his pain. We went ahead and scanned key portions of the anterior aspect of the elbow, which we believe was clinically relevant. For the anterior structures, we changed our patient positioning to supine, elbow extended, and supinated, and started to scan the brachialis. On the top left, you have the brachialis muscle seen in long axis without any abnormalities. And in the short axis cine, we confirmed that the muscle and muscular attachment to the ulna is normal as well. The anterior elbow joint was also assessed. We see that the brachialis is on top and the anterior ulnar humeral joint on the bottom. As we see medially to laterally, you can start to see that there's a small amount of fluid in the anterior recess. No loose bodies were noted still. and our report reflected this. Finally, to conclude our scan, we assessed the distal biceps tendon for any pathology. We used the medial approach of the pronator window to image the distal biceps tendon. We performing a dynamic pronation and supination to see that distal biceps tendon is intact, which it was. And our report reflected these findings. So before we discuss the final report, I do want to recap on the clinical presentation of Valgus extension overload syndrome. This is known as pitcher's elbow, presenting as a posterior medial elbow pain during the acceleration and deceleration phase of throwing. This is thought to be a constellation of pathologies stemming from the excess shear force of the Olecranon fossa articulation. And if we're thinking about throwing, there is a force extension in valgus torque at that acceleration phase that's essentially causing the medial tip of the olecranon right here at that diagram to abut the olecranon fossa. If the deceleration is not well controlled, such as with poor throwing biomechanics, then you can start to develop soft tissue swelling, posterior medial chondromalacia, and eventually formation of loose bodies, which our patient fortunately did not have. So for our final report, the initial report follows the AIUM guidelines for documentation. So we have patient identifying data on top, referring provider, the facility information, the clinical indication being posterior medial elbow pain. We have a comparison study being the right elbow radiograph and the use of linear and high and mid frequency transducers. So this slide is a busy one, but so for ultrasound findings, everyone has their own style when dictating the report. Some folks like the radiology narrative report approach, while others like a list. For me, I like to use a template listing for anatomical structures that were scanned, noting whether they're normal or abnormal. It's also worth noting that as a clinician ultrasonographer, it's also nice to include relevant clinical information. For example, we noted the snapping of the medial cutaneous nerve of the forearm, but we stated that this was asymptomatic for our patient. I highlighted here the abnormal findings that I believe were clinically relevant to the case. So recapping, at that medial ulnar humeral joint, we're finding mild spurring at the proximal medial ulna at the anterior bundle of the MUCL. For the MUCL, there was some mild thickening and hypogogenicity in the anterior bundle of the MUCL, as well as there was a tiny punctate anechoic region that may represent a low-grade intrasubstance tear. In the posterior ulnar humeral joint, we also saw hypertrophic bony spurring, mildly thickening, hypogogenicity, and hyperemia in the adjacent soft tissues. We saw large elbow effusion in the posterior recess, but no hyperemia within that synovium, no loose bodies. The medial aspect of the trochlear cartilage is also partially visualized, and that there was focal region of subchondral hypertrophy noted. We also noted a small amount of fluid in the anterior recess of that elbow joint. Finally, for our impression, we try to list here the most clinically relevant finding. So starting with, for the findings consistent with the clinical diagnosis of right valgus extension overload, including osteophytes at the medial epicondyle and medial olecranon adjacent bony surfaces, and focal irregularity of the subchondral bone in the medial trochlea. We also saw and appreciated right elbow joint effusion, and finally, a mild thickening of the mid portion proximal right medial ulnar collateral ligament in the anterior bundle without any laxity on stress testing. These are my references, and thank you.
All right, fantastic work, Gio. That was great. I'm gonna maybe let Ryan or Doug hop in with any comments here first.
Yeah, I can make a couple quickly. Yeah, Gio, great job as expected. You know, that's exactly what we want with these presentations, and you nailed it. So nice job. I guess I'll just make a couple points. I don't have a lot because again, you did an excellent job there. You know, from a protocol perspective, you know, I think this case highlights perfectly how we should approach these patients. So we have the recommended structures that would fulfill the requirements for a complete examination of the medial elbow, and we have some for the lateral elbow or for the posterior elbow. And you know, this highlights that we can use those structures as a starting point, but we really need to take in the clinical picture and the clinical question into account when we're scanning these patients and adding in you know, appropriate structures to really answer the clinical question. So for example, with this case, Gio, you know, you did a complete medial elbow, you added in some anterior elbow structures, some posterior elbow structures, which again is perfectly relevant and exactly what should be done for this patient. So I think, again, this just highlights that we really still need to include the clinical question when we're scanning these folks, and not just relying on, a checkbox list of structures to complete, a specific regional complete examination. So strong work there. My protocol for this, our baseball athletes here, I see a lot of them, and these are busy scans. There are a lot of structures to look at with these folks. So when I see somebody with the potential clinical presentation of valgus extension overload, I look at pretty much everything that you did. And the only difference, which is just a flow difference, is that I'll look at the entirety of the UCL. So I'll include that posterior bundle before I move on to ulnar nerve. The way that you guys did it is perfectly reasonable, but that's just my difference. I'll do anterior bundle, posterior bundle, then I'll move on to ulnar nerve. But again, that's just a stylistic point there. The neural structures are important to look at here. You mentioned this. Ulnar nerve in these athletes that have valgus extension overload, it's involved, maybe a quarter, 25% of the time. Usually that's mechanical symptoms. So it's, snapping out of the groove. But I have had a couple cases, I know Brennan has as well, where people have mechanical neuropathic snapping symptoms, and at the elbow, you look at their elbow or the ulnar nerve and things look fine. You're like, what the heck? You have nerve symptoms, you have mechanical symptoms, your nerve looks okay. And, it ends up being the medial interbrachiocutaneous nerve. So adding that, like you did into your protocol, is brilliant. And I think is something that we really should not forget about and not miss. For the UCL, so when I am looking at these, I tend to take both static images at rest and with stress. And then I'll also do stress cine loop and take measurements afterwards. That's just, I don't know, that's what I have done historically. I've done a couple patients, and I got this idea, I forget if it was from Brennan or Doug, but doing that side-by-side view, I think is an excellent way to do this. And, I'm certainly considering changing the way that I do my stress imaging, or at least my measurements here, because you can really line up the bony cortices nicely between your baseline and your stress image, and really get great accurate measurements. So I think either way is fine, but the more I do, I'm probably more inclined to consider using that side-by-side view. I think you're probably going back to get that slide. Once you get there, the other point I was going to make, so you can see on your images there, the bony cortices are exactly the same. So now you know that you're on the exact same plane of your UCL, and now you're taking accurate measurements here. The other part, you had a good picture when you showed the UCL with the ulnohumeral effusion. That can sometimes be tricky, I think, when you're starting out looking at these structures. So you can see fluid tracking, intra-articular fluid tracking up and sitting, that's cine loop, and sitting underneath the ligament, and you see that synovium that's deep. And I think, early on, folks can be inclined to call that like a longitudinal tear or a horizontal tear or a linear fissure within the ligament, but we can see that fluid that does track up over the top of synovium deep to the ligament. So it's just important to differentiate that fluid sitting on top of the synovium outside of the ligament versus fluid that's truly tracking intraligamentously. I think that, I think that is all that I had. I'm sure Doug, if you have some comments. Nice job, Gio.
Yeah, well, thanks. First of all, Gio, I mean, that's just how it's done. I mean, that was just a great presentation and exactly sort of the format. So obviously I'm splitting hairs here is because, again, the presentation was well done. Just a couple comments on the protocol, as we all do a little differently. So I usually start anteriorly, which is true for all my elbow exams. I do a short axis at the distal humerus at the articular cartilage. So I see the full picture of the anterior elbow. And then I go long axis to the joints at that point. And we've said this, a number of times on this format that, assessing the joints is important. But in this case, you make a great comment is you can see an effusion on the anterior elbow joints, but it's not necessarily quite as accurate as the posterior elbow joint. And so it's a great point, and I'm going to get back to that in just a minute. If I'm doing a medial elbow, I also just include the median nerve. If I'm doing a lateral elbow, as we talked about, I include the posterior interosseous nerve while I'm at the anterior elbow. Going medially, you had mentioned this in the report, but just to emphasize that the anterior band of the ulnar collateral ligament has an anterior and posterior bundle. So if you're newer to the UCL, just expect that you're going to see a plane between the anterior and posterior bundle as you scan the full width of it. And then certainly you see this on the short axis. And then also it's important to carefully assess the anterior bundle at the sublime tubercle, because you can have tears at the sublime tubercle and it may look normal at its humeral attachment. Another thing I add to my protocol once I go medially is kind of going anterior to posterior is there's some direct insertional fibers of the pronator teres onto the medial epicondyle. And that's a little bit anterior to the common flexor tendon. So that's actually a long axis image in our medial protocol. And I've seen some isolated tears there. So I've just kept it there over time. And then we won't kind of get into the weeds because there's so much good stuff with the ulnar nerve and the medial elbow. And again, assessing the medial antebrachial cutaneous nerve is advanced. And again, this shows your proficiency in ultrasound at this point, Gio. So that was great. So I want to make one other comment. And that is going back to the posterior recess in the Olecranon fossa. And so you showed the effusion there. And there is an important finding on that. And that finding is synovial thickening. And so in an acute effusion, let's say with someone who's never had a native elbow and never had a problem, you're going to see just a very thin synovium. But in this case, you see thickening and actually fraying of the synovium, which is well outlined with the anechoic fluid. And this finding suggests chronicity. And it goes along with, again, your diagnosis, and that there's been, in a sense, this valgus overload has occurred over time. And so now you get reactive synovial thickening. And where I see this often is that of the knee, is when we scan the knee, oftentimes with people with degenerative changes or a chronic intra-articular problem, they're going to have thickening of the suprapatellar synovial recess. And that's a clue that there is an underlying chronic problem. And so that's what we see in this elbow here, is we see thickening of the synovium of the Olecranon fossa, which again is indicative of something chronic going on. So again, that was a great job. Ryan, Brennan, Gio, have you actually, has there been actually a case report or a written article on snapping syndrome of the medial antebrachial cutaneous nerve, just out of curiosity?
Brennan, didn't you write up a case report or publish a case report?
No, we didn't. It's funny. I remember when I was a resident, I remember Jay Smith presenting on this at one of our internal sports conferences. And I remember thinking, like, gosh, I wonder how prevalent that is in the general population. That's something that someone should look at. And then I never got around to it. But I have not seen, I mean, people talk about it all the time, and I've seen it presented several times, and I don't know that I've seen anything in the published literature. I don't know if Jake or Ryan, if you've seen anything.
Jay Smith has a article with Sean O'Driscoll about, I think it's just a few cases actually, but nothing about like overall prevalence.
Yeah, I'm just trying to look right here. Oh yeah, that's back from 2015, the paper that Shelby's referencing. Yeah, Jay and Sean and Spinner. Yeah. Sounds like a great thing for a fellow to do, Gio.
Got it. Got the hint.
You've got a month and a half. 2 months.
You know, Ryan, I do what you do, and that is that with all my dynamic studies, when I'm, you know, and in this case, I just try to get the best, line up the best video I can of doing the valgus stress, and I just go back and get the narrowest point and the widest point, and then do a comparison measurement. So that's what I've been doing as well.
So Doug, that's interesting. You know, I think we've done a lot of work in this area over the last like year and a half with Jake and myself and Shelby and Jeff Payne. And I think initially we all did things a little bit differently. Like I used to just save a still at rest and a still at stress and measure them. And then sometimes I'd go back and compare, and the bony landmarks just didn't seem exactly right. And I know I think Jake initially, and he can comment if he'd like, did the cine and then would, you know, look just like you do, Doug. And then I switched to doing this still frame next to each other. And I just found I was able to way better get accurate bony landmarks. And actually the thing that clued it in, that really hit home for me, was the muscular landmarks above. I actually think are easier to line up than the bony landmarks are. And if you get the muscle, there's all these unique striation patterns within the muscle. If you get those lined up really well, your bony landmarks are almost always lined up really, really well. And so once I kind of realized that and switched to doing this side by side, rest and stress, lining up the muscle and the bone, I think it made it a lot more consistent for me.
Interesting. So on the image on the left, you'll get what you feel is your optimal rest image, and then you'll take a still photo. Then you'll go over to the control or the other side of the split image, and then you'll put them in valgus stress, not take a cine, but just line up the soft tissue and then hit it.
Yeah.
Maybe you'll backtrack a little bit on the on the trackball a little bit, and then lamp the soft tissue, and then you feel at that point you're more accurately getting the bony landmark.
I think so. I think it has like when I go back and review scans I've done, because I'll oftentimes scan and then I'll go up and review with our elbow surgeons, you know, as the patients come through. I find that I just have a lot more consistency on my measuring points when I do it this way versus when I would do it previously, or if I do a video and try and freeze it and save.
Yeah, that's a great point. I'm going to try that.
Yeah, like Brennan said, I the same way. I spent the first 8+ years of my practice using the cine method, and I've you know, we did a ton of scanning with the of baseball pitchers in the last few years with spring training and whatnot, and it's I feel like I can be more accurate or reproducible here because you can just look at them side by side, and I think that's one of the, as you guys know, one of the limitations, whether you're talking about looking at the knee or elbow when we're doing these dynamic measurements, you know, do you have the same bony landmarks or not?
I think it'd be interesting, and probably wouldn't be all that hard to do, but almost do like some sort of comparative analysis, looking at the accuracy of stress imaging of using that cine loop method versus the split screen side by side. Yeah, I think, like I said, I've done a couple of these. You know, the method that Jake, you and Brennan use, and it's actually been really nice, and I think fairly accurate. But it would be interesting just to see if there's any measurement difference between the two methods. Gio.
Gio, fantastic job.
Thank you.
All right. Well, I think we're running up on time here, so I think we'll end it there. Thanks, Doug and Ryan and Jake and Shelby for your comments. Gio, once again, fantastic job. You guys can join us again in a couple of weeks. We have Dr. Malia Kali presenting on May 26th on proximal intersection syndrome. So have a good weekend, everyone.